Can someone let me know if my audio is working? Okay, okay. Thank you so much for waiting. I am really sorry for being late. There was an unexpected interruption at my end. So let's start with retrosigmoid approach. I really hope that you have used this interruption as the breathing space to do the CP angle anatomy review very quickly. Because retrosigmoid approach is not difficult as long as you know the anatomy and you know where you are getting yourself into. So let's begin. So we have, while we were discussing the CP angle anatomy, throughout all these sessions, we have repetitively discussed the retrosigmoid approach as well. It is a lateral approach to the posterior fossa. I'll draw very quickly. Let's look at an image of the skull base. And this is a rough idea of the posterior fossa, right? Now we have our brainstem here in the middle. We have the cerebellum here, etc., etc. Please ignore my very poor illustration. This is a lateral approach to the posterior fossa. Why are we calling it that? Because we go from here. And we did discuss all the relevant structures that were around here. There were mastoidal cells, there was petrous apex, etc., very interior, but yes, somewhat in the neighborhood. So we have already established the basic anatomy so far. And we know that when we say this is a lateral approach to posterior fossa, why are we saying so? So what are some major indications? The major indications are going to be the pathologies in CP angle. The most common indication that we use it for is the vestibular schwannoma, obviously. But apart from that, a smaller a craniotomy can also be used for trigeminal neuralgia and microvascular decompression. Sometimes the same approach is also used for posterior fossa meningiomas. And if you are using the extended retrosigmoid approach, we will come to it, but we will discuss extended retrosigmoid tomorrow, inshallah. Just have this idea that if you increase your craniotomy and if you increase your bone work, you can increase your exposure up to the lateral side of the brainstem. So retrosigmoid is the workhorse of posterior fossa. It is also called lateral suboccipital approach. I'm sure you're all very aware of it. Let's move on. This is a very beautiful illustration which is showing us the difference between a conventional retrosigmoid approach and an extended retrosigmoid approach. Let me show you the differences. Even if you have never seen the extended approach or you didn't know about it previously, you just need to know two important things. The bone work stays the same. This is a craniotomy for the conventional retrosigmoid approach, where you stay away from the sinuses. This is our sigmoid sinus here. We stay away from it. Along with it, we have the mastoidal cells. We stay away from that as well. And there is a very small craniotomy that we make, roughly around 3 into 4 centimeters or 3 into 3 centimeters. And then we get excess. This illustration typically should have been like this. This is the region we get access to because we end up retracting the cerebellum towards the midline. Now, what happens is if you choose to extend your bone work and include some of the mastoidal cells into it, and you also expose the sinuses with sinuses, especially the sigmoid sinus, but you will need the exposure of transverse sinus as well. You skeletonize them. What do we mean by skeletonization? Can somebody mention? Can anybody let me know in the chat box if they don't want to open up the mic?
Ma'am, remove the bony, remove the bone above the sinuses up till the sinus ends on the other side.
Exactly. So we completely take away the bony covering, we dissect them free from the bone, and what ends up happening is we identify and we isolate a small cuff of dura and we leave it. What does it do? It gives us more exposure. We can now use that extra space. Let me try showing it to you. What ends up happening is if I make a flap now, you see there is no bone here. Over my purple marker, there is no bone here, right? The bone has been completely stripped away. Now, if I make my dural flap here and then I flip it on this side, since there is no bone, this dural flap is going to cover the sinus and it's going to stretch it like this. Is it making sense?
Yes, ma'am.
Let me see if someone else is unmuted. Okay. So what ends up happening is, since we have sandwiched it inside the covering of the dura, the sinus is secure, but it does give us more space. There will be an added 1 centimeter space, which is really crucial when you are approaching such small confined spaces. CP angle is a very confined space, right? So skeletonization of sinuses is only used when you need extra exposure, and they are in the extended approaches. If you're doing the conventional retrosigmoid approach, you are not going to need any skeletonization. You're going to stay away from the sinus and base your craniotomy accordingly. Like if you see, this is the sinuses here, this is the junction of both the sigmoid and the transverse sinus. And you can see, I'll mark the craniotomy borders. The craniotomy borders stay clear of the sinuses. We don't want to expose them because we want to prevent any inadvertent injury, any unwanted injury, right? When we are doing extended approaches, now these are the sinuses, but we are choosing them to carefully expose. So our craniotomy is going to be like this. We are choosing them to expose electively by our own will. Why? Because we need more space. We are going to use this cuff of dura, flip it on the other side, and get some extra centimeters of space. Is that clear?
Yes, ma'am.
Okay, moving on. Say, so since we are operating in confined space and we know we will be coming across some really important structures, especially the lower cranial nerves and the lateral side of the brainstem, we are going to need some intraoperative monitoring. Now it depends on institute to institute, setup to setup, and case to case as well. Your case, your institute, a lot of your resources, they are going to determine what kind of monitoring you have available. Ideally, in the ideal scenario, let me show you a chart. This is the ideal scenario. If you're working in a very resource-rich setup where, there is intraoperative neuromonitoring available in all its modalities, then for vestibular schwannoma, you will want the facial nerve monitoring, the cochlear nerve monitoring, and the lower cranial nerves. For facial, you are going to need the facial EMGs. You're also going to need the para or bear or the ABR. There are different names for the same auditory brainstem responses. You're going to need them. Along with that, you're also going to need the direct cochlear nerve action potentials. For trigeminal neuralgia, you're going to need the bara. Along with that, you're going to need the masseter temporalis EMG or a blink reflex. Now, this again depends on the institute. I have seen a lot of my seniors doing trigeminal neuralgia. I have assisted them, and in our institute, we did not have the facility of intraoperative neuromonitoring. So I know this will vary hugely according to the institute, but in any ideal scenario, you should be able to have all of this in order to keep the patient safe. Are we all on the same page? Because we are moving to the surgical steps now. The position I'm sure you are all very familiar with. We are going to put the patient in lateral decubitus or the park bench position, one of our favorites. But there are surgeons who prefer semi-sitting position. I have personally never used a semi-sitting position for retrosigmoid approach, for posterior fossa lateral approaches. Park bench works really well, but again, it varies from institute to institute and from surgeon to surgeon. What are some problems of semi-sitting position if we choose to use it? Can anybody share?
There's high risk of embolism.
Air embolism.
Exactly. There is a very high risk of air embolism, and that risk increases because we are working with two of the major sinuses, right? We are going to be working in the vicinity of the sigmoid sinus and the transverse sinus. So a semi-sitting position used for retrosigmoid approach will be, it will be a high risk situation, but there are surgeons who use it. So to each their own. Okay, so lateral decubitus and park bench position are more or less the same thing. Somebody's asking in the chat box. See, just like the lateral suboccipital approach and the retrosigmoid approach, they are both the same thing. So this is our lateral decubitus approach. You can see it. The patient is strapped. The head is slightly rotated. The contralateral arm hangs under the table. There goes the cushioning. The ipsilateral shoulder is strapped because we want more space in this region. So we strap it. And then the head is slightly elevated above the heart to increase the venous return. Now, if you look at this insert image, you can see a small craniotomy and a variation of incision. There are multiple variations of the incisions for the retrosigmoid approach. Let's come on the incision. Before you mark the incision, what are we going to do? We are going to mark the transverse sinus. It's not a good idea. You can still mark the incision, but then you will have some problems while you're doing your bone work because you will have no idea where the sinus went. So it's a good idea to mark the transverse sinus. How do we do that? I have another illustration, but let me draw here. So what we do is we palpate the mastoid notch here, somewhere around here. Once we palpate the mastoid notch, we go 2 finger breadths above it and roughly around the external occipital protuberance. And that is the surface marking for transverse sinus. What this is going to do is, this is going to give you a sense of orientation during your bone work. Apart from that, please remember there are 2 things here. There is mastoid notch, and there is another thing here, which is mastoid tip, right? They are both different landmarks and they are both used for different things. Mastoid notch will be used here to do the surface marking for transverse sinus. Mastoid tip will be used to guide our incision. Am I making sense? Am I audible?
Ma'am, if you could please repeat this.
Yes.
If you could please repeat this. Depend
There is
notch.
some internet issue at my end today, hence the delay in the start. Let me see if we'd be able to continue the session. Okay, so for the incision, we discussed that if we are going to need to mark the transverse sinus, once we do that, what do we do? 2 centimeters behind the external ear, the incision is going to go and it is going to end 1 centimeter inferior to the mastoid tip. Now, if you look at it, this is the mastoid tip. And a lot of residents end up confusing the mastoid tip and the mastoid notch both. Please remember, for incision, we use the mastoid tip. For transverse sinus marking, which they have, this one is probably the transverse sinus marking. For transverse sinus, we use the mastoid notch. For the incision, we use the mastoid tip. We go 1 centimeter inferior to mastoid tip. So you start roughly around the curvature of the pinna, and then you go all the way, palpate the mastoid tip, and then go 1 centimeter inferior to it. Now there are multiple variations of this incision, and again, it would depend on institute to institute and surgeon to surgeon. What I have personally used is this linear incision, the curvilinear incision. There are 2 other incisions as well. There will be people who will use an incision like this, more or less like this, and there's another incision, this S-shaped. It's making all jiggly, but let me show you. Okay, so yes, we have another image. So these are 2 variations. There is a third variation that you saw in this small inset, right? This U-shaped incision. That is also an option. I personally like this one, the curvilinear one. This S shape, what benefit does it have? What is the benefit going to be?
Lesser tension during closing.
Yeah, the closure would be easier. Apart from that, the exposure will be more. If you compare the exposure from a simple curvilinear incision, the exposure will be a lot more. So I think it will be a lot more useful if you're doing an extended retrosigmoid approach, because once you put in the retractors, this is going to get undermined more than a simple curvilinear incision. If you have used S-shaped incisions in your practice, you would understand what I'm trying to say here. It's very difficult to teach on the illustrations only, but you get it. I am not sure what your institutional practice is. The curvilinear works fine for a lot of procedures. You can now see the difference between the placement of retrosigmoid approach, which is also the lateral suboccipital approach. And then you can see this comparison of suboccipital approach. This is the paramedian craniotomy, by the way. This one here, in fact, this is not visible, I think. This one is our conventional retrosigmoid craniotomy. If I take it away and also go on to expose the sinuses, then it will become our extended retrosigmoid approach. If need be, and if your lesion is extensive or if it is placed very interiorly towards the brainstem, then you can also choose to open the foramen magnum. You can extend the craniotomy, go downwards, open up the foramen magnum as well for extended exposure.
Extended approach to improve the third as well, ma'am.
Let me see. Then we have the dissection. The dissection is carried out subperiostally, we all know that. You can use unipolar cautery on low current so that the muscle is not getting burnt. And you can also use a combination of periosteal elevator. Both work perfectly fine. The only problem is it bleeds, and the bleeding can be controlled easily with the bone wax while you're doing it subperiostally. Then what happens is, as long as you're on the muscle, it's still going to be a relatively straightforward approach. Once the bone work starts, it becomes slightly problematic in terms of the vascular structures which are underneath our craniotomy, right? The burr is going to be placed at asterion, which means we are going to be very near the junction of the sigmoid sinus and the transverse sinus. And the craniotomy is going to go 3 centimeters posterior, 4 centimeters inferior. Now, this again depends on the case. For example, you are not going to make a 3 into 4 centimeter craniotomy for a trigeminal neuralgia patient. For MVD, the craniotomy is probably 1.5 into 1.5 at max. 3 into 4 or 3 into 3 works well when you are doing large tumors like vestibular schwannoma, etc., etc. So craniotomy is going to be, the size of the craniotomy especially, it is going to be guided by the pathology you are operating on. Let me see. This is our stereo, and what we do is we go roughly 3 centimeters on this side and 3 centimeters on this side. For vestibular schwannoma, usually we go 3 into 3. You can go 3 into 4 absolutely if you want some more inferior exposure, or if you're planning to open a foramen magnum, that's a different thing. 3 into 3 usually works perfectly fine in all directions. Now, then again, there is another surgeon's choice in terms of, please just give me a minute. So there is another surgeon's choice. You can totally choose to raise a flap and then place it back. You can also choose to not, place it back. So craniotomy and craniectomy, that will again vary from case to case. How confident is the surgeon? And what was your surgical plan before you began? Because for my personal experience, I genuinely believe that posterior fossa is very, very unforgiving. It's always a good idea to leave the bone behind. But I know people who have successfully operated posterior fossa surgeries via retrosigmoid approach, and they have placed the bone flap back. Again, it depends on the institutional practice and case to case variety as well. Let me see. So you can now see the first burr, which is at asterion, and then you can see how big the craniotomy can get in terms of the inferior extension and the posterior extension. By posterior, I mean we are extending it to the midline. This is the midline, right? By posterior, I mean that I'm extending it towards the midline and I'm extending it inferiorly. They have raised a beautiful flap in this cadaveric dissection. You can see, and this can be placed very, very beautifully. But in posterior fossa, it's not a good idea. Posterior fossa is not a forgiving space. This is another image, an illustration from the Neurosurgical Atlas, and I believe it shows whatever we have discussed so far. Then again, you can see their craniotomy margins are closely following the transverse sinus and the sigmoid sinus. So we come to another point of discussion. There are a lot of points of discussion for the retrosigmoid approach. This is another one. I find it particularly interesting. Where are you going to base your dural flap? So you can do this. The other option is, let me mark. You can also choose to do this, flipping it on this side over the sigmoid sinus, basing it on the sigmoid sinus. This is one option. The other option is what is mentioned already here, where you're going to leave a very small cuff of dura, roughly 3 to 4 mm, around the sigmoid sinus and the transverse sinus, and then this dural flap is going to go here, and then you can put up tuck-up sutures to, aid the exposure. There is another option. This will be difficult while you're closing. What benefit do you think it will give?
It will protect both the sinuses, the sigmoid and the transverse sinus.
That's right. It's going to protect both the sinuses really beautifully, but it's going to be difficult in terms of closure once you are at the closure, until unless you have either a graft or artificial dura, this flap will be difficult to close. So the two conventional flaps are the ones I mentioned. Both of them are perfectly fine. It depends on your institutional practice and the surgeon's level of comfort as well. But please remember that this is something we are discussing in terms of conventional retrosigmoid approach. If you are doing the extended approach, then the flap is going to be based on the sigmoid sinus, and we are going to go like this because we will need this cuff around the sigmoid sinus to protect it. Let's look at the dural exposure. Now you can see this is the conventional flap. A lot of old school surgeons, people who genuinely believe in the conventional methods, they use this. They leave a very small cuff of 4 to 5 mm of dura around both the sinuses. And remember, this is cadaveric, so that is why the sinuses are exposed. In a normal patient, you would not expose them until unless you are going for the extended approach. You will leave this cuff and then retract the flap on the other side, and then you can put up the tuck-up sutures or stay sutures in order to aid the exposure. This is another illustration which shows the, let me see, turn on my, this is another illustration which shows both the flaps. You can see both directions. This flap is based over the sigmoid sinus. The other flap is our conventional flap, which is based on the free side of the bone, and you're leaving cuff of the dura around the sinuses. Let's see. Once we are done, I tried finding images for the arachnoidal dissection. I could not. Once we open up the dura, this is not the view you're going to look at. The view is more or less going to be very cloudy. And why is that? Because there will be CP angle cistern and an arachnoidal covering, which you will have to open up via very fine dissection. Once you open up the cistern and all the CSF is released, then and only then you are going to get this view. Even then, probably you would not get this view because this is cadaveric. There is extensive exposure. How do I know there is extensive exposure? Because once you put in the retractors, please keep yourself muted. My internet is not very forgiving today. Okay, so once we open this up, how do I know this is undue exposure? In a normal patient, you are only going to have either this view, let me see, or this view if you are going superiorly, or this view if you have unfortunately exposed way more than you should have. If you're doing it for the vestibular schwannoma, exposing lower cranial nerves unnecessarily is never a good idea. This exposure is going to suffice, this small one. How do we make sure? Always use dynamic retractors. Cerebellum is very unforgiving. It will quickly develop contusions and the patient will have problems post-operatively. So use dynamic retraction just in the middle portion. Subtle retraction, drain the CSF, and then you wait for the anatomy to show. Usually 7th and 8th are very perfectly visible once they are open. The only problem during exposure is once you know the lesion is very huge and it is starting the normal anatomy, and then you're not sure which nerve is which. Otherwise 7th and 8th complex is very easily recognizable. The only problem is if you're doing it for trigeminal neuralgia, you're doing a microvascular decompression, then the 7th, 8th nerve complex can be a confusing thing. you might think that since it's big enough and since trigeminal has multiple roots, it could be trigeminal, but trigeminal is, as we have discussed before, it's going to be superiorly and it's going to be deeper. For trigeminal, you will need to retract slightly more, slightly superiorly, and you will have to go deeper. It will not be as easily visible. See all of it? So this is 7 and 8. What will I see first? Once I open it up, what will I see first? 7 or 8? 8th nerve,
Eighth
right?
cranial nerve.
Eight.
Yes.
Eighth
7th
nerve.
is interior. Even in a normal patient, 7th is going to be behind the 8th nerve. And in a patient with a vestibular schwannoma, you will not be able to see 7th nerve at all. It will either be hidden or it will either be stretched completely on the tumor capsule. Since we have done the CP angle anatomy in thorough detail, I am just going to show you some pictures very quickly, and then we are going to conclude today's session. You can see another beautiful image. Cerebellum is on this side, and the bone is on this side. You can see this 8th nerve. You can see the 7th nerve hiding behind it. You can see the ICA. And behind that, you can see the 5th nerve is there, but it's deeper. So for the 5th nerve, you would have to go deeper. Apart from that, we have the superior petrosal vein, which was a very interesting point of discussion in our previous sessions. This is our superior limit, and I cannot see it on my screen, but I'm sure if I'm using a scope, there will be tentorium here as well. This is another image, cadaveric, obviously, of CP angle. You can see all the anatomy very beautifully. Choroid plexus, I would like to mention, is not going to be visible if you're going to go for retrosigmoid approach, vestibular schwannoma surgery, because this is going to be slightly inferior. Our target is not here. We are not going to retract this region. If you are retracting and unfortunately have exposed the lower cranial nerves while you are working for vestibular schwannoma, the lower cranial nerves are very unforgiving in terms of post-op deficit. Patient inadvertently develops, dyspnea, dysphagia. It's not a pretty picture afterwards. So the best way to protect them, even sometimes I feel that even better than monitoring, the best way to protect them is to keep them hidden as you can in terms of necessary exposure. Apart from that, there's nothing new here in terms of anatomy. Let's take a very quick look. You can see the superior petrosal vein, the 10th, which is our superior limit. We have the trigeminal nerve, and we have the 7th and 8th complex along with ICA. And this is another cadaveric image. These are the endoscopic images. They're more interesting somewhat. You can see the 10th here and here where my cursor is. This is the superior petrosal vein, the 7th nerve, the 8th nerve, and once we go deep, in the depth there's going to be the 5th nerve, which you can see here. And they have taken the scope deeper. Once they have taken it deeper, you can see the 5th nerve and how deep it is in comparison with the 7th and 8th nerve. So that's it for today. We are going to do the drilling of internal auditory canal tomorrow and maybe touch upon the extended retrosigmoid approach. Please leave me any questions if you have on the WhatsApp group. I'll try getting back, inshallah. Thank you so much, everyone. This is a wrap for today. If I've missed any questions in the chat box, you can always leave it on the group